Welcome to a spirited conversation about PTSD and developmental trauma disorder, the pros and cons, sponsored by the University of Connecticut Center for Treatment of Developmental Trauma Disorders. My name is Mariah Bruni O'Brien, and I will be facilitating today's webinar. Before we begin, I would like to share a few reminders. If you experience technical difficulties at any point, you may email us at help@nctsn.org. The format of this webinar does not allow for you to speak directly to the panelists. However, we encourage you to use the Q&A feature on WebEx. We will try to answer questions that are submitted throughout today's webinar. We encourage you to review the background information provided prior to this webinar. This document can be downloaded anytime from the NCTSN Learning Center. Today's training will be archived on the Learning Center website. This makes it possible for you to view the presentation at a later time, as well as complete a short evaluation, the CE post-test, and print a CE certificate at any time. For anyone wishing to receive CE credits for this training, no hard copy certificates will be mailed. The National Center is approved by the American Psychological Association, National Association of Social Workers, and the California Board of Behavioral Sciences to offer CE credits. Today's webinar, a spirited conversation about PTSD and developmental trauma disorder, the pros and cons, will be moderated by Dr. Rocio Chang, co-director of the NCTSN Category 2 sites, the University of Connecticut Center for Treatment of Developmental Trauma Disorders, and Dr. Isaiah Pickens, Assistant Director of the Service Systems Program at the UCLA Duke National Center for Child Traumatic Stress. Dr. Chang and Dr. Pickens, would you like to begin?
Yeah.
Thank you, Mariah. Yes. So on behalf of Dr. Pickens and I, we're very happy to introduce the distinguished faculty professors and directors of amazing centers, Dr. John Briere, the director of the Center of the USC Adolescent Trauma Training, Dr. Michael Subak, the director of the Complex Trauma Treatment Network, and Dr. Julian Ford, the director of the Center for Treatment of Developmental Trauma Disorder. So without further ado, we would like Dr. Briere to start first.
If we could advance to the next slide.
Do you want me to speak now, or were you going to go over the pros and cons?
Why don't we do the pros and cons first, just so the audience has a kind of a sense of the topics that we're going to be addressing?
Yeah, so really are you going to do that, Julian?
I would be glad to do that, sure. We wanted to have this conversation because we realize that PTSD has played a really important role in our fields, and in working with children and families who've experienced traumatic stress for, gosh, almost 40 years officially. And yet for a long time, pretty much that entire time period, there has been concern that PTSD doesn't cover the full range of post-traumatic reactions that children have, that adults have. But PTSD itself has some remarkable strengths. I mean, it's been developmentally adapted for young children. It really does protect against multiple kinds of polydiagnosis, because many children were diagnosed with a wide range of disorders before PTSD was actually formulated. And now it's a diagnosis that captures many of the internalizing and externalizing problems that traumatized kids have experienced. And it's widely used as a focus for screening in many different service systems. And it really does provide a way for clinicians to focus their referrals for evidence-based treatments. And it doesn't require any additional new learning of assessments or treatments beyond those that have been established over the last several decades for PTSD itself. On the other hand, next slide, PTSD often is not just alone. We all know as clinicians that PTSD often co-occurs with many other diagnoses, and in spite of using the diagnosis of PTSD, it's not at all uncommon for children to have multiple diagnoses: ADHD, other externalizing behavior, disruptive behavior disorders, internalizing disorders, depression, anxiety disorders, sometimes bipolar disorders, psychotic disorders, attachment disorders. There's just a wide range. So PTSD itself does not necessarily protect against both polydiagnosis and, in some cases, the utilization of just multiple medication treatments as well as psychological or instead of psychological treatments. And it doesn't directly address affect dysregulation, which is something we'll be talking a good deal about. It does address some of the negative affective reactions, some of the mood and affect states that are well incorporated in PTSD, but the actual dysregulation of emotion that can be such a trouble for children who've been traumatized is not directly addressed in PTSD, although maybe that'll be a part of what we'll discuss. And it doesn't directly address the kinds of attachment and insecurity and attachment disorganization problems that can often lead kids to have reactive attachment disorder, dysregulated social engagement disorder diagnoses in the DSM-5. And it does require the reporting or observation of re-experiencing and avoidance, which sometimes are very difficult for children or even their caregivers to actually identify and to recognize as occurring. So DTD, Developmental Trauma Disorder, if we can go on to the next slide, that was really developed over the last 15 to 20 years. And a group from the National Child Traumatic Stress Network really spearheaded this, led by Bessel van der Kolk and Robert Pynus, a wonderful group of people that really were thinking, how can we do for children who've experienced a wider range of difficulties something similar to what's been done for children and adults who experience very clear-cut post-traumatic stress, fear and anxiety kinds of reactions. And it actually was an attempt to keep PTSD from becoming too complex by providing a kind of a companion diagnosis that wouldn't be a replacement for PTSD, but it might be something that could help to either better focus assessment and treatment for some children, or it might be something that could be considered as concurrent with PTSD alongside of the PTSD diagnosis. So DTD really focuses on dysregulation of affect, emotion dysregulation, and that includes bodily dysregulation too, which is very common for children, where they experience their emotions and distress and difficulties in either being overly activated or really shut down emotionally, not necessarily as emotional reactions, but as bodily physiological reactions. So affective and physiological dysregulation is one component of DTD. A second component is a dysregulation of attention, thinking or cognition, executive functioning, so to speak, and behavior. And in DTD, the focus really is on some of the difficulties that have to do with a preoccupation with threat that extends beyond hypervigilance, which is a core of PTSD. It's the threat not only of physical danger and harm, but threats to relationships, threats to a sense of self, and that kind of a preoccupation can then drive a child or an adult, but in this case a child's entire personality development and self-development. And it can lead to then behavior that is very reactive, that can include self-harm, it can include reckless or potentially dangerous behavior, it can include behavior that is basically disorganized in a sense where this is a child who may seem as though they just can't concentrate and focus long enough to set goals or achieve goals. And yet it may not be because they can't do it. It may be because they're experiencing the internal dysregulation that then interferes with good judgment, thoughtful behavior, and successful goal attainment. And the third element in DTD, just to get it on the table, is dysregulation of relationships and sense of self. And of course, a child's sense of self really develops in the context of their core relationships. And if relationships are very, very tumultuous, if a child is tending towards either being overly engaged and enmeshed or very intensely detached from and distrusting of relationships, they're very likely to develop difficulties with just who they view themselves to be. And that can lead not just to difficulties with self-esteem, but a fundamental self of uncertainty about who I am as a person, why other people would care about me or like me, what kinds of people I can trust and people who I would want to be close to, as opposed to people who I really am not safe with, how close I can be, how much responsibility I have for people in relationships. Am I only valued because of what I can do for other people? Do people only care about me if I'm making them happy or fulfilling their requirements? Do I have to take care of others and be a kind of a parentified child? All of these really complex kinds of reactions to a fundamental sense of insecurity and unsafeness in life and in relationships, that's really what we're talking about with DTD. So it really does provide a basis for helping us as clinicians and our clients to understand what happens to a child when they've both been victimized and they've had fundamental disruptions in their primary attachment relationships. It focuses on self-regulation in those domains, so it really gives a kind of a singular focus. It's not just a set of symptoms. It really is a way of mapping the ways in which children can become dysregulated so that we can help them to recognize those and recover from those kinds of dysregulation. And it really directs treatment toward the core of affect and bodily self-regulation and dysregulation. And it provides a basis for assessing externalizing problems that are sometimes just identified as basically being a bad child or a bad kid, when indeed most of these children and youth are very well-intentioned, they're good kids at heart, and they're struggling to survive, and they're externalizing aggressive, impulsive, and otherwise quote-unquote troublesome behaviors are often a reflection of really an attempt to survive in a world where they don't feel that they have the relationships to protect them and the caring to justify their worth as a person. So it expands hypervigilance to include the kids who are not just focused on threats, but who literally seem to be unaware of threats. And they're biased in their attention, but they're biased away, a very subtle form of avoidance. It includes dissociation, not as a core feature, but as one of the potential symptoms. And it relates to the PTSD dissociative subtype, but it is different than that because it includes forms of affect dysregulation that go beyond what we see in dissociation alone. And finally, it does focus on the kinds of core beliefs that children who are traumatized and feel unsafe in their relationships often develop just in order to survive. So last slide, and then we'll get into the true discussion. With all of this, DTD is by far away not a perfect classification or potential diagnosis. It's complex, so it really does make treatment targeting challenging because there are at least 60,000 different types of potential PTSD diagnoses, and PTSD is actually potentially less complex than DTD. So the variety of potential treatment foci that DTD could lead to are very complex, and we'll talk about that. The lead-in criterion to DTD, which is the exposure criterion, criterion A, that includes a wide variety of childhood traumas. It's focused on victimization and attachment disruption, but it goes beyond any specific type of attachment disruption and any specific type of victimization. So it can be really quite complex to actually pin down. It requires screeners and treaters to learn yet another set of diagnostic criteria. So it's adding more work, and that's a potential challenge, as well as it's a challenge to make this widely enough known so that it can actually be used appropriately and fully. And it's only been assessed in one small, but I think still valuable field trial, which we may talk about. And we don't really know whether it reduces polydiagnosis and polypharmacy. We believe that it could, but we're not sure about that. And it really does overlap with many other DSM and ICD disorders. So it might just be a combination of other disorders by another name. So there's a quick highlight. That's what we're going to be talking about. And now let me turn it back to John Briere to give us some thoughts about how to sort out all these complexities.
Hi, this is John Briere. With Cheryl Langtree, I'm the director of the USC Adolescent Trauma Training Center, which is a Category 2 center of the NCTSN. Although the title of this implies a lot of debate and perhaps heated debate, I imagine we're all basically going to fall at some point on the same dimension. Certainly, I believe that both PTSD and some version of the kinds of things described by DTD would be relevant to lots of children, adolescents, and adults. And certainly within the complex trauma field, you know, we all acknowledge that the outcomes can be quite complex, and that unfortunately, to some extent, the current DSM gives us choices like PTSD or borderline personality disorder or one of the child behavioral acting out disorders as our only options, and clearly we need to have more options than that. So I would certainly not disagree with the notion of complex trauma. And, you know, we're all in the same boat. We all do research on complex trauma outcomes. The other people you're hearing from in this discussion are my colleagues, and we're more aligned than separated. Rather than an adversarial position, I think what's more interesting is for us to just highlight the different perspectives that come with different sort of ways of thinking about complex trauma presentations, and examine the underlying ideas to see if we can augment them or change what we understand to have a more full understanding. As a trauma specialist like we all are, I use PTSD diagnosis quite often. I do think the DSM-5 has both improved and in some ways maybe injured our PTSD criteria. A major advantage of DSM-5 over DSM-4 that I don't think is talked about too much is DSM-5 does expand criterion A to include more than one trauma. So what this does mean is that you can give a diagnosis of PTSD based on multiple traumas, not linking all those symptoms to the same one, and that has helped us a little bit in looking at more complex outcomes. Unfortunately, the model of PTSD is still I think based on its original perspective, which was to look at combat vets and adult traumas, and not so much in the kind of developmental issues that Dr. Ford and others are outlining. My central view here about complex trauma is that obviously no two people are going to have the same scenario. They're not going to have the same diagnostic pattern. We're pretty clear based on research done by people on this panel that the number of different traumas you have, the types of traumas you have, the duration of those traumas, all are going to have impacts on what kinds of symptoms manifest, what kind of problems, et cetera. And so, indeed, as Julian mentioned, you're going to get vast numbers and permutations of symptoms as a function of what the lived experience of that person was. Also, when we look at the kind of stuff we're talking about today, we're looking really a lot at the notion of attachment disruptions, and if you want to call it that, attachment disorders, which is interesting because, as we know, DSM does not consider attachment dysregulation to be a trauma per se, which is probably a fairly serious oversight. I would submit we either have to change the definition of trauma or use another term. But a huge amount of the emotional regulation, self-perspectives, relational capacities, et cetera, that are suffered by people with developmental difficulties in this area are due to early attachment dysregulation and disruptions. And so it makes it so it's not really developmental trauma, it's developmental adversity disorder or something like that. It is obviously multidimensional. If you heard the list of different kinds of presentations that Julian outlined so well, there's obviously high multidimensionality here, and as a statistician kind of guy, it makes me a little nervous to have something that's so multidimensional that we would collapse it into a single dimension, which we essentially do by giving a diagnosis of developmental trauma disorder. But as he points out, PTSD is no better situation. PTSD, usually in structural equation models or factor analyses or higher order analyses, dimension reduction analyses, show up with 4 to 6 to 7 to 8 different components of PTSD. The other major diagnosis that aligns with adults, at least in older adolescents, is borderline personality disorder, which probably is even more multidimensional. So it's not that developmental trauma disorder is multidimensional and the other ones aren't, but I do think we have to think about how complex this diagnosis is and whether we can actually collapse it into one thing. Because what obviously is going to happen is some people are going to have certain criteria, other people are going to have others, and we either eliminate some because they don't have enough criteria, or we say they're all equivalent when their criteria may be different. Also, I think most dimensional analyses nowadays have moved away from dichotomous thinking that you either have or you don't have a disorder, and certainly something as multidimensional and continuous as complex trauma outcomes probably, it may not be perfectly served by a dichotomous got it, don't got it diagnosis, although of course sometimes we have to, for writing up case reports or for advocacy, we have to talk about dichotomous scenarios. And then lastly, at least, and what I would mention right now would be there's massive cultural mediation and moderation of symptomatology. Idioms of distress vary from one culture to the next. Within America, we have culture and subcultural differences in presentations such that on top of trauma and attachment, we also have the cultural scenario in which the person is embedded in the way in which they experience their symptoms and express them to others. You need only look at, for instance, ataque de nervios. Ataque de nervios is basically somewhat of a complex trauma outcome, most typically found in Puerto Rico, but also found elsewhere in Hispanic or Latin cultures. But it's not identified that way at all. As a complex trauma disorder, it's identified as a completely different disorder. And it reminds us that we want to make sure whatever we call complex trauma, developmental trauma disorder, that we don't anchor it in the experience of European stock Americans, when there's such dramatic variation from, say, sub-Saharan Africa to other areas. And then there are gender differences. We just have a paper coming out now in psychological trauma showing that for PTSD, for borderline personality disorder, the structural equation models and the measurement models for borderline personality disorder vary considerably as a function of the gender of the person, including the etiology of those problems. So I guess overall, how do we develop this useful construct, whether we call it developmental trauma disorder or complex trauma disorder per ICD-11? Can we develop a construct that summarizes what's going on but doesn't pathologize, and at the same time doesn't gloss over differences or collapse dimensionality and honors cultural differences? So we were just, and I'm saying this with great respect, but we want to be very careful that we're not just taking one series of diagnostic criteria which are relatively problematic and creating a new version of them which includes more variables, but at the same time may share some of the same problems with our original formulations.
Thank you for that opening statement, John. We appreciate that. We will go to Michael now, if you could provide your opening statement.
Sure, great. I first want to thank you all for inviting me to be part of this panel. I feel a little bit out of place and honored to be included with such accomplished and esteemed colleagues. And that's kind of my nice way to say more senior colleagues. I mentioned that in the spirit of the spirited debate. I want to start my opening statements with just sharing a couple brief observations. First, based on my experience in the trauma field, which I know a lot of people that know me don't realize I'm this old, but it's been about 20 years now. There seems to be multiple camps in the field, which might be described as a PTSD camp and a complex PTSD camp. And one thing that I've always found a little unfortunate is that there seems to be such an adversarial relationship between the two camps. It almost feels like a turf war at points. And I strongly feel that the trauma field has enough room for several different camps. And one of my professional goals has been to try to build bridges across these camps. And I think discussions like this will only help. So once again, thank you for including me. And a lot of the points that I'm going to just mention in my opening statements are echoes of what has been said before. But the second observation I'd like to make is that, and this observation illustrates my primary issue with not only PTSD, but also complex PTSD. And this was referenced in the slides that were shown earlier. Gallitzer and Levy and Bryant in 2013 developed an algorithm and demonstrated, as we saw in the earlier slide, almost 80,000 symptom combinations that could produce a DSM-4 PTSD diagnosis. And they updated this with that it's now increased to over 600,000 symptom combinations for the DSM-5 criteria. So my biggest issue is it reasonable to believe that each of these 600 plus symptom combinations represent one distinct entity? The last open observation I'd like to make as part of the opening statements is that prior to the publication of DSM-5, Bruin and colleagues put forth an alternative pared-down version of PTSD, and this included only 6 symptoms: 2 re-experiencing symptoms, 2 avoidance symptoms, and 2 heightened sense of threat symptoms. And to meet a diagnosis, you would need to endorse 1 symptom from each of those groups. And this became the basis for the ICD-11 diagnosis. I like that proposal. Why? Because I think it represents a distinct entity. However, I also realize and believe that that's not enough. And that does not capture the variety of ways that psychological distress can manifest after the exposure to trauma. So I think, and I think we're all aware of this, that the challenge that the field faces in developing a classification system for trauma-related psychological distress and dysfunction is that we need to capture all the various ways that trauma can impact a person. And 2, these diagnoses need to be specific enough for researchers to be able to identify underlying mechanisms and for the development of more specific and targeted interventions that could perhaps increase the efficiency of our treatment and interventions. I obviously and unfortunately don't have the answers, but I'm grateful to be part of the discussion. I have some thoughts about maybe ways to go forward that I'll share during the later conversation. So thank you.
Thank you for that statement, Michael. Great. So thank you so much for those opening statements. And Julie and Dr. Ford, we would love to hear both your opening statement and in response to what you heard from your 2 colleagues.
Thank you, Isaiah. And thank you very much, John and Michael. Those are really thoughtful and very, very clear foundational kinds of perspectives for us to take, to kind of stand on, to use in this conversation. And I really couldn't, you're so right, John. I couldn't agree with you more. And Michael, you're so right. I think that building bridges and not having schisms between people who are true believers in or against developmental trauma or complex trauma and complex PTSD, it's so important that we find ways to bring these concepts together and not look at ways to split them apart. And I think that's the tenor of this whole conversation, which I think is really wonderful. And in doing so, then we can think about ways in which the constructs and the assessments, as John has spoken about and has tremendous contributions to the literature, and the treatments that John has innovated in and Michael has been incredibly innovative in developing targeted treatments that are exactly what we need, so that we're not trying to just use a shotgun approach or a one-size-fits-all approach, because clearly there are so many different potential combinations of reactions to developmental trauma for children, depending on their age, their gender, their culture, their family background, all of those factors. So in the spirit of keeping this simple smart, I will oversimplify for a moment. And when I think about developmental trauma disorder and PTSD, think about why are they important and what do we need them to do for us and to help our clients in particular in their recovery from experiencing adversity, which may or may not be DSM-5 trauma, but it nevertheless can leave a lifelong impact that is described by either PTSD or DTD or both. And the way that I try to kind of carve this close to the joint is thinking about the stress response. And when I think about the classic stress response of freeze, fight, flight, and then the last stage of immobility, that, I think, is really an interesting framework. You know, that's where Marty Horowitz, who was one of the true pioneers in developing the construct of PTSD, and he really focused on intrusive re-experiencing and avoidance, and that the kind of vicious cycle that can occur there, really was talking about the stress response cycle, where a child who is exposed to events or experiences that are beyond their comprehension or that are terrifying or that leave them to feel deeply, deeply alone and unprotected or unsafe or betrayed or exploited, that child then is going to react with a bodily stress response, which is absolutely adaptive. It's crucial to survival, crucial to be able to get through the experiences that they're challenged by. And when I think about the stress response, and I try to kind of map it onto PTSD and DTD, here's an initial attempt, and I'll be interested in what others think about this. So I think of PTSD as really encapsulating the initial freeze, fight, and flight aspects of the stress response, where those features, the freeze response is really the orienting response, the mobilization for potential threat or assault, and it looks like a very relaxed, calm state, but actually the body is very, very activated. And that then moves into the fight response if there is actually a threat or harm or danger. And that's an attempt to ward off the danger and protect against the harm. And then if protection or getting rid of the source of the danger is not possible, then trying to get away and take flight is, of course, the natural response. It seems to me that PTSD does a very elegant job of describing what it's like for a child or an adult to be basically living in a fairly constant state of either mobilizing, freezing, or being in a fight or flight mode. And in some respects, I think it's unfortunate that PTSD was taken out of the anxiety disorders classification in the DSM-5, where it had been in DSM-4 and before. Not because I think anxiety is the only thing that's happening in PTSD, but because I think, and there's ample research and clinical evidence to support the idea that it really is a fear-based disorder. And people like our mentors, like Edna Foa, have been brilliantly describing the core elements of fear that is expressed in PTSD and that can become a preoccupation for a child in their entire life, even when they are objectively safe. Then when I think about the next stage of the stress response, the immobilization phase, which is not as commonly referred to because we usually think of fight-flight, but immobilization seems to be what happens when there is no escape and when the danger, the predator, the harm, the adversity is ongoing or could be ongoing or resumed at any moment, and there's really no escape. So that's the response to entrapment, and it's a kind of a shutdown. I think that is very interestingly parallel to the dissociative subtype of PTSD that's been identified, work of Ruth Lanius and colleagues in the DSM-5. And that kind of immobilization is not always classic dissociation, but there's a lot of commonality between dissociation, the kind of tuning out or fragmenting even of the self, and not being present or not being able to be fully present, and a kind of an immobilization where the individual, the child, withdraws. So dissociation and immobility have a lot in common, even though dissociation can sometimes be accompanied by hyperarousal. And then once you go beyond that, what I've thought is that maybe developmental trauma disorder is a way for us to begin to understand what happens when a child is not just engaged in freeze, fight, and flight, is not just at times immobilized and not a voluntary choice, but just literally immobilized because their body cannot sustain any further involvement and their mind cannot fully comprehend what is happening. Maybe DTD is an expression of a kind of a disorganized stress response. So paralleling the disorganized attachment construct that developed when insecure attachment and other forms of the ambivalent attachment difficulties were not sufficient to really categorize some children who just seem to at times be insecure, at times be rejecting, at times be enmeshed. What if DTD was a way to describe children who at times are freezing and then at other times they're in a major fight mode and aggressive and reactive, and at other times they're incredibly avoidant and potentially even at times fully shut down and not able to even really engage, and possibly so shut down that they even find that self-harm is the only way to really be able to attain any degree of affective toleration. So that's my opening thought, that maybe the stress response syndrome, as we understand it, can help us to understand how PTSD, dissociative PTSD, and DTD might represent a way of understanding the spectrum of complex, ongoing, traumatic, post-traumatic responses without trying to unravel 600,000 different potential symptom presentations. And with that, I will turn it back to our moderators.
Mm-hmm. Julian, can I add something to that real quick?
Of course, Michael.
I think, Shelley Taylor's writing on the stress response system included one other aspect, which is tend and befriend.
Yeah.
And I think that might be an important element to consider, since, that the opportunity to tend and befriend in situations where trauma is occurring might not be available.
Could I add something as well?
I think we're into the discussion phase. Let's go for it.
Yeah.
I would really agree, Julian, with the sort of the implication, although I'd go a little further, that the DSM PTSD version is based on fear and stress. And then it seems like what you're doing is extending that stress to other typologies and explanations that go more into the DTS area, which makes perfect sense. I do think, without disagreeing with that, I would add to that, though, that the importance of attachment and attachment dysregulation, and as you mentioned, disorganized attachment, doesn't just have to do with stressed neurobiology associated with, the loss of a caretaker and the fear of death, as Bowlby would describe it, but also just the effects of disattunement and relational unpredictability and a lack of security and stuff, which is not exactly fear or stress-based. I think one of the things we want to look at is, does fear cover the ballpark? Is that it? And clearly, when you were talking about, when one was talking about Vietnam veterans, fear was very relevant. But when we start talking about, were your parents sufficiently loving? Were they attuned to you enough? Were they connected to you enough? Obviously, that can engender fear in the child who expects abandonment and then biologically perhaps death. But I think, would you all agree that as we go deeper into the attachment, we start looking at working models, we start looking at emotional regulation systems, et cetera, which are not actually just fear-based. So I think one of the interesting aspects of this discussion of PTSD versus some kind of developmental trauma perspective is whether we're looking at the same thing. Is criterion A even the same for the two? And if it's not, how do we deal with the overlap, et cetera? Hugely important in all this, as Julian mentioned, is that emotional dysregulation is also present in PTSD by implication, but is obviously a huge part of developmental trauma. So I wonder if we don't have to stretch that out a little more. The last thing I would want to see, and this is complex, and I certainly don't have the answer, but when I hear what I've heard so far today, and obviously a little familiarity with the literature, I worry that developmental trauma disorder is too big, that it just encompasses too many things that vary so much by person to person that saying that someone, quote, has, unquote, DTD, it may be a different thing for one person than the other one. Some people may predominate more with fear, some with more with emotional regulation problems, et cetera. So I just think that in here we have both theoretical notions of what are the discriminations between PTSD and something bigger, but then the other heuristic rubber hits the road problem, which is this thing that's being proposed, is it handleable? Can we, in fact, I know there are interviews, and I know there are and will be psychometric instruments, but is this just two-dimensional and too big to be very useful in and of itself clinically? And I could actually argue the other side of that, but I just offer that as something to talk about.
And John, I'll add on to that again and say that I'm not concerned if it's the same thing, because I really think when you have between PTSD and DTD and complex PTSD, you probably, I don't know the number, but there's probably 6 discrete entities there that could be carved out. And I think that's where the problem is, like lumping too much together.
And I think those are really great points. I want to highlight, I don't think I was clear enough in saying that fear is what I think is really the driving force in PTSD, but stress, I think, which extends well beyond fear, because stress is a reaction to potential danger, which could then lead fear to be the stress reaction, but it's also a reaction to disattunement, as you were saying, John, exactly, to the absence of the tending and befriending response, which I'm so glad you mentioned, Michael. I think that's a really crucial, and that's in some ways a kind of a marker or a doorway toward potentially considering what recovery involves. But when you don't have the tending and befriending, when you don't have the attuned caregiver, I think that the reaction is one of not necessarily fear, but it is stress. And the kind of stress reaction then could be more like the complex, disorganized variety of some fight, some flight, some just absolutely shutting down and immobilization. So with that, it does seem to be pretty complex. And one of the things that I learned from being a part of this field trial study that we have done on developmental trauma disorder was that when we looked at how best to identify kids who met the criteria that we were proposing for DTD, which I've described, what we found was that the core set of symptoms that were most important and that needed to have the most of those symptoms present in order to capture kids who really were impaired by these kinds of threats to their emotional and interpersonal as well as their physical survival, were the affect dysregulation items. And so even though in the proposed formulation of developmental trauma disorder, there are only 4 affect dysregulation symptoms. They're complicated, so they're not simple in and of themselves. But there are only 4 of them. And there are 5 cognitive and behavioral dysregulation symptoms, and there are 6 relational and self-dysregulation symptoms. But it was the affect dysregulation symptoms, we needed to see 3 out of 4 at least. So pretty much every aspect of affect dysregulation that we could identify had to be present for a child to then have sufficient impairment to meet or to be clinically significant as a true indicator of a serious treatment-related problem or treatment-requiring problem. It only required 2 of each of the other 2 sets of criteria, cognitive and behavioral dysregulation and self and relational dysregulation. Not that they're less important, but those are the ones that are much more variable, and those are probably the ones that may be trying to add too much in, as you were saying, Michael. And I think that's really a good point that we need to be thinking about. Maybe we can't include all of those different features, but maybe we need to figure out which elements of those kinds of dysregulation are really at the core, rather than having a longer list that you could have 2 out of 6 or 2 out of 5.
The only thing I would add to that methodologically is that you're basically saying what best predicts among a core set of symptoms the presence or absence of the core set of symptoms. What if the thing that we're trying to predict is not what we're actually needing to predict? So you're saying that affect dysregulation seemed to be, and I would completely agree, by the way, that affect dysregulation would be a big part of what you're calling developmental trauma disorder. I just would raise that what if that's not, what you're trying to predict is not actually the domain that's exactly what's going on with these kids. Maybe we haven't come up with the right list yet, and maybe emotional regulation is a different problem. I mean, if you just think about internal working models, idealization, devaluation, lots of other things that may not involve stress per se, although they have some etiology in that, may not involve fear and danger. You know, how do those things interdigitate? What's the overlap between borderline and PTSD? So I really hear what you say. There is a little tiny bit of circularity that maybe you can clarify for me, that you're basically saying in the data set you found, you developed some underlying dimensions or sources of variance, which could be best, if I understand it, best predicted by these emotional dysregulation items, which is exactly what I believe. But the question is the underlying construct that's being best predicted by emotional dysregulation, is that really, is that the best way to articulate whatever's going on with these?
I can give you a quick, and give the audience a quick clarification, because that's an excellent point, John, and then I want to give it back to Michael and to the moderators. The clarification is that what we were predicting was not the DTD symptom set or the dimension, the underlying dimensions. What we were predicting was psychosocial impairment. So we were predicting something that was distinct from the symptoms, but that was kind of the bottom line. Is this child having significant difficulties in life that are probably going to require some kind of therapeutic assistance?
But Julian, that you could say that about, is depression creating those problems? Is it an anxiety disorder? I mean, you're not really saying DTD is psychosocial impairment. You're suggesting something larger. So if your criterion variable is that the kid's having a rough time, maybe it's due to ADHD. And so the fact that you can find emotional regulation problems predict psychosocial impairment, I wouldn't be surprised, but that's not actually, doesn't speak directly to DTD per se, unless I'm missing something.
Well, you just made one additional excellent point, and we channeled you in thinking about this, because what we found was that combination was predictive of psychosocial impairment after controlling for the effects of multiple other diagnoses. I didn't add that, but I should have. So we actually looked at, did these kids have symptoms that were consistent with ADHD, with oppositional defiant disorder, with depression, with anxiety disorders, with a whole range of childhood and other psychiatric disorders. And independent of those other disorders, this particular combination, and particularly affect dysregulation symptoms, were predictive of psychosocial impairment.
Okay, just one thing about that, then I'll shut up. This is probably best discussed over Chardonnay, not in something that...
I think it's great for people to hear this.
Stats person, we worry about something that's called partialing the relation out of itself, which is if you control for too much, do you still have what you started with if what you have was a mixture of comorbidities? So I would be worried that if you controlled for all those things that you just described, what you have left isn't probably DTD anymore. It's DTD when you don't have all those other problems, and that may not be a good criterion variable in which to determine what the real problems are. I mean, what would it be like to have developmental trauma disorder without any of those problems? Would that still be developmental trauma disorder? If it becomes an artificial variable, which the partializing literature in stats talks about a lot, is that actually something that has external validity to what we're originally talking about, which is developmental trauma disorder?
Good question.
So I think
we'll talk about that over Chardonnay.
These are excellent questions. I think everyone pulled out their Chardonnay for this discussion. And what we want to do here, because you all really went deep and had some really great insights about the etiology and even some of the phenomenology of some of these disorders, but I want to shift the discussion a little bit and kind of talk about this practically, especially for a lot of people who are clinicians and work with kids who might be experiencing these issues. I want you to kind of explain to us from a DTD or PTSD framework how we might go about identifying resilience and adaptive behavior as it relates to this, because what we know is a lot of these kids, especially who have experienced multiple traumas, still live in unsafe environments, and sometimes the actions that they're showing are maladaptive because it's not suited to the environment that they're in, but they are still actually in situations that are unsafe. They have to show kind of heightened behaviors to protect themselves. And so could you break down how the DTD and PTSD framework helps us better understand how to support adaptive and resilient behavior among youth?
Well, I would just mention that some of the biggest criterion A stressors aren't in criterion A, which have to do with racism, homophobia, poverty, social marginalization, governmental policies vis-a-vis immigration, et cetera. Those are massive stressors, and a lot of our kids are not suffering from post-traumatic stress disorder. They're suffering from ongoing stress disorder. And I agree that any treatment that when we want to do it in the real world, working with the real kids that we see in these abject, horrible situations, we have to address the social and cultural issues that undercut resilience at a very basic level. If you try to treat a lot of the kids that we see in our inner city LA emergency rooms with classic evidence-based treatments, they can't even attend to the treatment, and it may not even be very relevant to them because they're worried about, is dad still going to be alive, or is mom going to be alive, or I had to step over a body to get to see you today. The issues are quite different. So I really like the notion of looking at resiliency, but I think we also have to look at it as I think you're talking about, as a culturally embedded phenomenon, and that we can't get too tied up just with treating this as if all we're really looking at is a disorder or a diagnosis, when these are things that kids are struggling with on an ongoing basis. And then, of course, the important question is, what allows some kids to do better than other kids in that circumstance? Although I don't think there is an invulnerable child, and I don't think there's full resilience. It's a dimension as well.
Thank you, Dr. Breer. I'm wondering what the group thinks about community resilience, going along with some of the conversation that's happening. Do you think, does community resilience play a role in some of the treatments that we can provide to these populations who are highly marginalized and who actually, as you described it, Dr. Breer, they are facing ongoing stress?
I mean, I'm not an expert in this area, but I think the obvious answer is yes. And the example that I've heard come to mind, which I think is a good one, is if you look at the overall community cultural reaction to 9/11, which was horrible. However, there was this sense of spirited coming together. Even Democrats and Republicans were coming together a little bit after then, and I think that may have shaped the way that psychological distress after 9/11 played out, as opposed to other other contexts in community and cultural issues like the genocides that happened in Rwanda. I think it's obvious that the community resilience and community resources and lots of aspects of communities play a part. I personally just don't know the specifics and how that works out.
And I would strongly agree that, first of all, resilience, as John said, it's often based upon being able to continue to develop and grow and have a life and create a future in the face of ongoing adversity, and communities that are able to basically provide, going back to Michael's earlier point, to provide that kind of crucial tending and befriending the mentoring, the protection, the providing of a sense of the value of each youth, each child. When communities do that, and we see that in some of the most horrific situations, as Michael described, we see that in situations now that are facing so many marginalized communities in this country, as Rocio said, and internationally. When communities, when there are people in communities and sometimes institutions that actually nurture children and give them a true sense of how it's possible to regulate emotionally and be in relationships that are actually trustworthy and safe. I mean, I know it's in some ways it's kind of a cliche, but that makes all the difference in the world. And the resilient individual is much more likely to come from a resilient community. And we often lose track of the fact that it's not the individual alone who's resilient, it's that they are being provided with the kind of support and the role modeling and the caring that enables an individual to be resilient. And that comes from the community, even when the community itself may be drastically in danger and experiencing all kinds of threats and adversity.
I mean, I just want to make sure that we don't end up blaming the community if this fails, because the problem, and I know you're not trying to do that, Julian, but I just raised this as a larger point. The problem is you have an oppressed, marginalized community. They're not going to be able to take care of their people as well as they might have had they not been exposed to those kind of external forces. And so I think in many cases, this kind of, here it comes again, that in some sense we have to make political change as much as clinical change. It's what Julian Rappaport talked about. Instead of pulling people out of the river, why don't we go upstream and stop whoever's pushing them in? The issue here would be that many of the communities that we're seeing are impacted by things beyond their control that impair their ability to do what they otherwise could do. And that, of course, is when we have to take a larger picture on trauma, resilience, and outcomes.
These are really great points that you guys are bringing up, and I believe Michael might have been about to say something, but I wanted to bring into this conversation, how do we integrate our understanding of intergenerational and historical trauma? Because we've been talking about how an individual experiences, and we've been talking about the community at a large, as a whole, but there's this intermediary component where the families play a role. And so how do you see integrating this from a both PTSD and a DTD framework?
You're asking good questions.
I mean, I can talk, but talking too much. I mean, historical trauma probably involves everything from the effect of slavery and mass incarceration and hate crimes to epigenetics of the transmission of stress from one generation to the next. And it's really large. And I really applaud any analysis that says, you know, these aren't just people who are suffering from what happened to them now. They grew up in a family and they came from a culture or a history that was associated with a lot of injury in the past, and we can't overlook those things as well. How we actually treat that is the subject of some debate, but obviously we don't really know. It's certainly a good thing to think about.
And I'll add that I think that actually, this is, I'm going way out on a limb here because I have no evidence, but just for the sake of our brainstorming together as a group and with our audience, I think that that potentially the kind of reactions that are created when there is mass trauma that extends over generations, like slavery or genocide, and that really is very likely to generate a kind of an intergenerational transmission of fear, of being very, very sensitive to and likely to react with a fear response, because that's exactly what you have to do if you're going to survive under those kinds of conditions. But it also, what gets transmitted across generations is resilience as well. And that's something that we sometimes overlook. I actually think that DTD can be very helpful in the sense that PTSD focuses on okay, parents whose parents and their parents and generations before them have experienced tremendous threats and horrific conditions, they're going to be primed physiologically, probably, both genetically and somewhat epigenetically through their own life experiences, to be very sensitive to threat in a way that would then make them at risk for PTSD because they're adapting, not because they're maladaptive, because they are just literally very, very adapting. On the other hand, those same individuals, those same communities, rather than thinking of them as at fault, we can think of them as they transmit some core values which literally supersede and extend well beyond the fear response. And those core values have to do with valuing the individual, with being able to maintain a degree of emotion regulation so that you can remember that you're talking to another human being and not think of your child or your neighbor or your spouse or other family members or other community members as an enemy. That intergenerational transmission of affect regulation and of a sense of the importance of relational connection, I think that's also transmitted across generations when there is historical adversity and trauma. And if we look at those two things side by side, we begin to see that in order to promote resilience, we need to not only help people deal with their fear responses, the PTSD aspect, but we also need to help them bring forth the capacities that are kind of the opposite of DTD. And so in some ways, maybe DTD would be better framed as a kind of the antithesis of adaptive regulation, and we need to focus more on what adaptive regulation is rather than on the dysregulation that we are looking at with DTD. So I would propose that the historical issue is one of looking at the transmission of fear, but also looking at the transmission of adaptive regulation.
And I just want to add two things. One is, I think what you mentioned is right. One of the things that gets passed down from generation to generation, in addition to genes, is beliefs and values. And that's one important point. But I would also say one thing that largely passed down from generation to generation is wealth and resources. We like to think of the myth of meritocracy in the U.S., but there's strong data to suggest that you're going to be about as wealthy as your parents were. And, wealth is related to available resources.
That's a great point, Michael. Sometimes I get so caught up in the psychological, emotional, relational aspects that I forget that tangible resources, as Stephen Hopfall has also pointed out very brilliantly, are very, very important, and the scarcity of tangible resources or having a corner on the market on tangible resources can be a very unfortunate perpetuating factor of some of the kinds of problems that we're talking about.
Thank you.
I have a question to pose, if it's okay.
Sure.
And my question is, we're focusing a lot on PTSD and DTD. My understanding of the data is that almost all, not all, but almost all mental disorders are associated with increased rates of exposure to traumatic events. And I think that one thing that gets lost is, I don't think as a field in general, we don't focus on how a variety of mental disorders are impacted by the presence or absence of a significant traumatic, a history of being exposed to traumatic events. And I think that, when I think about the approach to understanding, a comprehensive understanding of how trauma affects mental health, that needs to be included. And, there are some exceptions, and what comes to mind is, and I hope I pronounced this right, but Teicher's work on looking at how things like depression manifest differently based on the presence of neglect or the absence of neglect. and I think he has also done some work at looking at things like psychotic disorders and how the manifestation of psychotic disorders is impacted by whether or not someone has a specific trauma background. So I just wonder, what the two of you think about trauma and other diagnoses.
John, would you like to start? I think that's a great question, Michael. Have we temporarily lost Dr. Briere to an attachment disorder?
I'm just going to...
I'm muting attachment disorder.
That's what I had. I think that this is a very good point, and it points to the general relationship between adversity, and especially childhood adversity, and any kind of psychological outcome, with perhaps a few very strongly biologically based disorders. And I think it reminds us that we have to be very careful when we start developing these broad diagnoses that cover so many different domains, because we may be actually stealing things from one disorder and from another and combining them in some kind of novel way. There's no question that there's good research showing that schizophrenic individuals who have delusions, who have been traumatized, have different kinds of delusions than those who haven't been traumatized. And they have different hallucinations, or at least to some extent. There's a lot of data showing that the various anxiety and depressive disorders are strongly impacted by trauma. So I think your point is really a good one. I do think we're trying to struggle with that in the field, to look at all these interrelationships. But I think it does point to the potential danger of having very large, heterogeneous, multidimensional labels for things that may, in fact, reflect a bunch of different processes that have as their origination attachment or trauma-related difficulties.
And I agree completely. If I had to just go on my preference from the point of view of the work that I do with clients as well as in research and teaching, I wouldn't create a whole new diagnosis, because I think that there are all the problems with any diagnosis that we're all talking about. They're all imperfect. They all put people into a category when any two people in that same category, in the diagnosis category, may have radically different symptoms and need a fundamentally different approach to treatment. But given the fact that we, unfortunately, for research funding as well as for clinical services reimbursement, we are fairly well stuck in a situation where categorical diagnoses rule. If we can go upstream further, as your example and Julian Rappaport's point really highlights, John, we should be thinking about ways in which we can alter the healthcare system so that it's not so reliant, in the behavioral health area at least, it's not so reliant on diagnoses, because it's just not the same thing as medical diagnoses, and even they are very complex. But given that, if I had my preference, I wouldn't create a new diagnosis at all. I would just point out that any time that any client or patient is being assessed for any disorder, that the impact of trauma should always be considered, and that the impact of trauma is not a disorder or a diagnosis. It's a set of complications that are very likely to exacerbate or possibly, as you said, with the psychosis, John, modify the actual presentation or nature of the disorder, and that if that is not addressed, and in particular, I would focus on either basically the fear responses and hypervigilance that is involved in PTSD, and I would focus on the affect dysregulation that's involved in so-called DTD, that if those two potential exacerbating features are not addressed, that any treatment is likely to be less successful and any chance of recovery is likely to be less. On the other hand, if those are addressed, then there is a greater likelihood that the treatment for the index disorder, the so-called the apparent disorder, is going to be more successful. In order to do that, and then I'll stop, we need to then have targeted interventions that are not directed at PTSD or DTD, but that are directed at very specific components that then could be treated within the context of treating any other disorder when they are relevant. And I sort of think that might be a good segue to the approaches to treatment that the CTTN and the Adolescent Trauma Center have been developing very effectively.
Julian, I think you just perfectly summarized exactly what a lot of us think, and I think you did it in a very elegant fashion. I would note that even for the pharmacologic treatment of PTSD, nowadays people don't try to treat PTSD, they try to treat the subcomponents, and different drugs are better at, or worse at treating individual components. And so just as we're talking about individualized medicine, I think we should be talking about, and we are, talking about individualized treatment where we're not distracted so much by the diagnosis, but what are the underlying dimensions of difficulty.
And that really is integrated treatment of complex trauma, which John and Cheryl have done such wonderful work in developing. It's also attachment regulation and competence, which Michael's Center and Sparks, structured psychotherapy for adolescents responding to chronic stress, and a variety of others, child-parent psychotherapy that Alicia Lieberman has developed. So many of our interventions for complex variations on the theme of PTSD or DTD are specifically addressing these core components and not necessarily trying to treat these large humongous disorders as if they were a monolithic entity.
Yeah, and one thing I would just reiterate is I just think it's unfortunate that it's not standard protocol for any type of like assessment study or any type of diagnostic process to include an assessment of trauma history. That should be standard with, anxiety disorder studies. And I think if that happened, we would be able to have data to help us understand things better. And I just wanted, if I can just make one point. I'm basically solely a researcher, and I think one thing that I would like to emphasize from a research perspective is that we also need to be a little bit more broad with our methods. And I think one thing that in particular, one issue is, even with John, he talked a lot about factor analysis, confirmatory factor analysis. Those are very important. We've learned a lot about them, but there is also a distinction between person-centered approaches and variable-centered approaches. And variable-centered approaches are things like factor analysis. And they're very good at identifying symptoms that are important for a specific disorder. However, they're not good at identifying groups of people. And there are some person-centered approaches, and these include things like cluster analysis, latent class analysis, latent profile analysis, and growth mixture modeling that really focus on identifying groups or individuals who share particular attributes. And these are, very well suited for addressing questions that concern differences in patterns or signs and symptoms among groups of people. And, I think you see a little bit more out there, like, for example, I know that Poitra has looked, applied latent profile analysis to, a sample that was assessed for PTSD, complex PTSD, and borderline personality disorder, and looking at across all the symptoms of those disorders, they were able to identify 4 distinct groups. So I won't go on long with that, but I also think part of the answer is kind of diversifying our research methods a bit. And another example is, network analysis is something that's up and coming. I think, as a field, we rely too much on variable-centered approaches like factor analysis.
I Really, am I, okay, I'm on. I really agree with that. I do think, though, that there is a reductionism that's sometimes found in these cluster algorithms where you basically find a group that has no symptoms, a group that has a lot, and a group that has some. And so what we obviously need to do is look at the interface between different modalities of statistical analysis and different modalities of dementia reduction. I only mention this because I think we sort of, the snake feeding on itself, you know, we decide that it's one way, so we use analyses to look for that thing, and we miss other analyses. Obviously, this is going to take, you know, a bunch of different approaches and look from a bunch of different perspectives.
So thank you guys. Go ahead, Julian.
Just a quick point, Isaiah. It's very useful to identify people, groups of people who have a common profile of either difficulties or strengths or both, or different experiential backgrounds. It is a problem if all you get from those analyses is a high symptom, medium symptom, low symptom group, or a high exposure, low exposure group. But I think there are enough of these studies, as Michael's pointing out, that have identified groups of children and adolescents, as well as adults, who have fairly qualitatively different profiles in terms of either what they've experienced. Sometimes it's multiple forms of trauma, sometimes it's sexual abuse, sometimes it's traumatic loss, and those are quite distinct, even though they can end up being treated as if they're all just a form of the single entity that we call trauma, when indeed they may have very different effects and they may play out in very different ways. So as long as we're not just getting a simple high, medium, low out of these kinds of analyses, or three factors that just happen to group the symptoms in a particular way, even though they don't actually occur in those groupings most of the time for most people, as long as we don't get any simplistic reductionistic results, those are really important ways to begin to identify what are the patterns in these kinds of difficulties that we need to be aware of. So we're not trying to just treat every single symptom. We're trying to, nor are we trying to treat monolithic disorders. We're trying to look for patterns where there are common threads of experience and symptoms that then might guide us as clinicians. So back to you, Isaiah.
Thank you. And building on this very riveting conversation, we have a question from the audience that focuses on how we understand the relationship between the concepts we're talking about in military vets and their children. And just wondering if there's any insight, kind of like early in the PTSD movement, we got a lot of insight from looking at military veterans. Is there any parallel to that for DTD and some of the other topics we're looking at?
You know, I don't know if there's a link between, and Michael or John may know more about this, between children who have experienced traumatic stress and military vets, other than that there are some common reactions when the dynamics of that experience, whether it's entrapment or shock and horror or moral injury, when we look at those kinds of more qualitative aspects of adversity or trauma, those have some similar kinds of downstream effects for kids and for military veterans. It's just that in many cases, military veterans are at such a different stage in their development that they can be, their whole lives can be affected, obviously, in major, major ways, but they may start with a base of attachment security, of resilient affect regulation, and that may then enable them to recover in different ways or be resilient in different ways than a child who is just developing that kind of foundational set of capacities.
There are data bearing on these points. There's the Navy recruit study, of which I had a little involvement. Basically, what we found, and it's been validated by other studies, is that people going into the military actually have considerably higher child abuse histories and more trauma than other people do. This was so dramatic that we even got some pushback from the Navy about publishing results that said that Navy recruits were actually had some pretty serious trauma load, allostatic load going into the military. We also, I think we know that current traumas can be dramatically exacerbated by previous traumas. So certainly in military medicine, military psychiatry, and psychology, there's often a focus on what they call pre-military factors to see. It's basically a complex trauma model to say, is why is this guy having such a major reaction to X adult event? He should be because, or she should be because she's going through a very bad thing, but she may have had childhood events that are adding to it or accumulating along with those other traumas. So I think we do see that there's relationships there, and it's actually, I consult a little bit to the military, it's actually a big thing that's dragging some parts of the military into a complex trauma perspective, which is to realize that combat is usually not the only explanatory variable. It may not even be the largest explanatory variable for the symptoms that some people feel. And, you know, I think it's the same thing we're finding with torture, sex trafficking, and other areas, which is these are horrible events, but they can be made even more horrible or have even more severe outcomes when there are those childhood traumas underlying them or antecedent to them.
And I think with the military, too, you can almost think of it as a unique culture. And, you know, a lot of the training that goes in creating a good soldier leads to, like, cognitive processes and patterns of responses that are just maladaptive in civilian life. And that's one aspect, but there's just a whole cultural element to the military that's important to consider.
Thank you. Another great question from the audience. The audience would like for you to start talking a little bit more about hospital medical trauma. Can you say something about that type of trauma?
Well, there's little question that invasive medical procedures early in life are not good for kids, and the extended stay away from parents because they're being hospitalized are bad for them as well. Our model, integrative treatment of complex trauma, actually started with including a fairly significant number of kids who were treated for everything from AIDS to early cancer to other kinds of problems. And clearly, if you were sick enough to be in that kind of intensive care environment, you're obviously being traumatized by those events, but also the treatments, the invasive surgery, the time away from your attachment figures adds to that problem considerably. So it's a very good point to raise, and there is actually a whole sub-area in trauma around looking at the effects of invasive medical procedures on post-traumatic outcomes.
Yeah, and which is also, and it's also important to consider in those situations, you often have a significant physical injury to go along with the psychological distress.
And I would add that there's another factor related to the separations, the sense of potential threat, the injuries, is pain. And I've been fascinated for many years. Glenn Sachs, more than 20 years ago, he and his colleagues in Boston noted that when kids who came into hospital for emergency acute treatment, if they had significant pain and they were provided with relief from the pain, with, of course, the clear question of being very cautious about prescribing any kind of analgesic that could be potentially dependency encouraging, but when they were actually provided with relief from the pain, they were much less likely to develop the kinds of symptoms that we're describing in PTSD and DTD. So that doesn't say that eliminating pain eliminates the potential risk of developing these kinds of stress or fear-related problems, but it does say that in hospital and other medical treatment settings, it's important to keep in mind that it's not just the physical injury or illness or harm, and it's also not just the emotional distress, it's literally also the physical pain that can potentially contribute to the risk of some of these very serious stress-related problems.
Thank you so much for these rich responses. We are coming to the end of this wonderful webinar, so we want to be able to give each of you a little time to make some closing remarks. as we move towards the end, and just any reflections you have about this discussion, future directions, and implications for some of the new conceptualizations that we're looking at. And why don't we start in the order that we started, and you each have about a minute or two to share your thoughts. We'll start with John, move to Michael, and end with Julian.
I think as often occurs when we think we're going to set up an adversarial situation, if we have people who are not heavily invested in that, we tend to find a lot of commonalities. I actually felt that I almost completely didn't disagree with anything that anyone said today. I thought this was a great Cook's tour, whatever that is, to the complexities of this experience and the study and research that's involved. And I'm very pleased with the way it went. And I think that we probably landed on the same spot ultimately when you looked at overall what we were saying.
I 100% disagree with John, and I put that in there just to add some adversarial nature to the discussion.
Okay,
no, just kidding.
We're not listening to you, Michael.
I agree, and I think I made all the points I wanted to make during the discussion. Again, I makes me excited when people from different backgrounds come together in a non-adversarial manner. It could lead to fruitful discussion. And again, thank you all for including me.
Well, I will only add that
a much shorter time. So, yeah, Julian, you have a full 3 minutes to speak if you like.
Oh, no, I will be brief because I want to thank John and Michael for some really, really thoughtful, insightful points. You've given me a lot to think about. I've gone from being an absolute devotee of DTD to being a much more flexible guy, and it's because of having conversations like this, quite seriously. And that I think is really crucial because as much as I would like to see DTD brought into the diagnostic armamentarium so that we are not missing out on that as a potential way to help guide treatment and identify kids who've had very complex trauma histories, I also am now thinking much more cautiously about how there are other paths to be able to actually bring this kind of information into treatment that may actually be more acceptable to clinicians who are not as oriented to assessing trauma, as you pointed out, Michael, and who may actually not want to be burdened by an additional diagnosis, but might be very willing to consider if there are interventions and ways of identifying issues that could complicate the treatment and that could potentially help them to enhance the outcomes of the treatment that they are using for other diagnoses. And my last thought is that I would love to see this conversation continue down a particular path that I'm interested in. So I'm setting this up as a potential follow-up webinar. I think we could have some really interesting conversations about the implications of PTSD and DTD for the core of PTSD treatment now, which is trauma memory processing. And I've been giving a lot of thought to what is actually involved in trauma memory processing and why it is so important and why it can be done in so many different ways. And I know that Michael and John have some really remarkable knowledge and expertise in this area. So I'm hoping that maybe we can take this conversation into that arena in the future. But thanks for this.
Thank you all so much. And we didn't have a chance to get to all of the questions. There were a lot of great questions. If there's any contact information the panelists want to provide, either now or to us, we can get it out to people. But I'm not sure if anyone has additional questions. They can contact certain sites for the National Center, the National Child Traumatic Stress Network, to get in contact with you all as well. And I'll pass the Rocio to close this out.
On behalf of the whole team here, we really want to thank John, Michael, Julian for such a wonderful conversation, and we are really looking forward for you to join us again on the next series dealing with a reluctant disclosure of sexual exploitation. Thank you so much to the audience for their participation and their attendance. Have a wonderful day.
Thank you.
Thank you.
Thank you.
Thank you.